Davina, let's start with you as the Director of Sacred Heart Supportive and Palliative Care Service. Can you tell us a bit about the history of Sacred Heart and Palliative Care Services at St Vincent's?
Thanks, Olivia. So it is a privilege for me to be a director of Sacred Heart because it's, as we've heard, been around for 135 years. Not many people realize that it is the oldest hospice in Australia. And it's because of the Sisters of Charity and their compassion for people that were not being looked after. So you bring back yourself to 135 years when the treatments are not as good as today. And when there was no treatments available, patients were left dying and not being looked after. And the sisters saw that need. They had the compassion and they saw people suffering and they decided something needed to be done. And with that, they set up the hospice. Now, it's not a sexy topic to be talking about dying, but people in the community responded to that. So people came to volunteer, doctors, nurses. These were not paid clinicians in those times, and they came, and that service grew from a community response to what was needed at that time. There were donations to buy the land, to provide equipment, and that compassionate work has resulted in the later years in the HIV epidemic where, again, this was a period of time when no one knew what was going on with how HIV patients were being looked after and patients were dying from HIV, but it expanded to look after patients in that era. So for a long time, Sacred Heart was an independent entity separate from St. Vincent's, but in 1980, St. Vincent's was integrated with, Sacred Heart was integrated with St. Vincent's. And as some of you may know, Professor Richard Chai, and at the time he was appointed as the clinical chief and the director of supportive care then. He's only stepped down recently, but he's still very much with us and very active in looking after patients. That expanded to include, the work at Sacred Heart expanded to include rehabilitation services, so Professor Stephen Foh has been part of that. And in more recent times, we've also changed our name to expand to become more than just a hospice, but the Sacred Heart Health Service.
And how have you seen Sacred Heart Health Service and palliative care grow and adapt over the years?
It's a really good question. So I think when we talk about palliative care, most people have a understanding that it's the last days of life. And palliative care is much more than the last days of life. We have patients who have been on our books for a number of years. So it's really about patients who have a life-limiting illness and how we look after patients with those conditions. There have been studies that show that people who are referred to palliative care actually live longer because we manage their symptoms better. And as a result, we're getting earlier referrals, but that also means that we are able to help with some of those symptoms and discharge them. So again, there's this misconception that patients come to us and that's it, but we actually get patients home. If you manage their symptoms, I will acknowledge it's not all patients, but we do that for a large proportion of our patients. And because of that, there are more patients that are also being looked after at home. So as part of the Sacred Heart Health Service, it's not only an inpatient facility or the hospice, but the community team has also grown over the years, and we have a multidisciplinary team that is looking after patients at home. And with that, I want to acknowledge that we have had so much support from Margaret and Stevens Sesgetti in their very generous donation a few years ago, which has enabled our service to continue to grow. In terms of keeping patients at home with the community, so the funding, the gift that they have given us allowed us to buy equipment, things like hospital beds, commodes, wheelchairs, things that we need to keep patients at home that some patients might not be able to afford, but because of this gift, we have been able to keep patients at home for longer. And with the funding, we've also been able to support our staff in higher education. I think 2 years ago, we had a national palliative care conference, and about 50 of our staff were able to go. Some of them, I think, and I was there as well, to upskill ourselves, to learn what's out there, how can we better look after our patients, what new information is there. And we also had nurses who were part of postgraduate studies that we could support with that funding. We supported our bereavement manager to do distance education. So there's just many examples of how that funding has enabled our staff to upskill, to be aware of what's out there, what's cutting edge, so that we can implement some of these things in our service. And also the money has been used to look at how our service should be growing. So one of the things that we've done in the last couple of years is set up a palliative care in the home service, which supports patients really at the end of life to remain at home. But we had to look at some of these numbers. How do we use the data that we have to forecast what might be happening so that we can actually be strategic about how our service grows? And without that funding, that would have not been possible.
Incredibly important. Thank you, Davina. That's a perfect lead in to you, Allison. You've seen so much of that evolution firsthand, from the white tunic and pinafore days of the early 90s right through to the scrubs of today. Davina touched on how palliative care has adapted to meet the changing needs of patients in the community. What are some of the key services you're involved in?
So thanks, Olivia. So I certainly have been at St Vincent's for a long time, and it's a great place to work. I'm part of the community palliative care team. My particular focus is working in residential aged care homes, and we provide services and support to 22 aged care homes across the St Vincent's catchment area. And for a bit of context, that represents about 1,500 people, and that's about the population of Huskisson, not at summer peak time of the year. So it's quite a lot of people to see. And our program works really collaboratively with a multidisciplinary team. I particularly focus on aged and palliative care in residential aged care homes. And you'll notice that I'm saying residential aged care homes, and that's been the recent change that's coming through. For such a long time, we've referred to them as facilities or institutions. And for me, it's really important to recognise that it's someone's home, and so the care that we provide as part of St Vincent's is in someone's home, and whether that's their long-term family home, whether it's a unit that they've moved into, or whether it's a residential aged care home, the care is still the same. The difference is possibly that if we're seeing someone in a residential aged care home, their comorbidities or different care needs incline them to be a bit more frail in the first instance. And they do have slightly more access to professional support and equipment that's available to them and to their families. So we work very much with the sort of the sphere of people we work with grows. So it's with always the person at the centre, but with their family, with their friends, with the people that matter to them, and with the staff in the aged care homes. So what we try to do is build the capacity of staff members and confidence in delivering quality palliative care, and recognising that that's not just the last moments of someone's life or the terminal phase, but leading up to that and taking that opportunity to understand what matters to the person, exactly what sort of disease progression we might expect for them, what symptoms we might see, and how we can best support them and the people around them to have those symptoms well managed. And we've worked really hard to make sure the model of care of service that we deliver at St Vincent's aligns really strongly with the new aged care standards, with the recommendations from the recent Aged Care Royal Commissions, and also with the changes to standards and practice in aged care that come in place in a couple of weeks. So we've worked really hard to make sure that we align with what's going on in the community and what community standards and expectations are.
I'm sure a lot of us are wondering, how can families be supported to best meet their needs and the needs of the person they love and understand their options? Allison, what are the differences between receiving palliative care as an inpatient in a nursing home or in your own home?
So for me, the principles are the same wherever you are. So the principles are about making sure that the focus of care and the goals of care are in line with the values and the wishes of the person, that their comfort and their dignity is our absolute priority at all times, and also that the people around them are well supported and have all of the information available to them to make good decisions. So this can include conversations often about what types of treatment to explore, the limits, or we talk about the ceilings of care, about how much care we might provide, whether someone would want to return to hospital for further treatment investigations, or whether we shift the focus of our treatment to their comfort and managing their symptoms. So in terms of the work that we do in the residential aged care space, it's often working with a wide variety of people. So we work really closely with our local GPs, with facility staff, with their education teams. And when I talk about facility staff, I think it's really important to talk about registered staff and care managers, but also about the personal care staff who are providing that day-to-day assistance in really personal, intimate moments in people's lives to make sure that they've got access to support and information so that they can recognise changes and communicate that information really clearly. I would say about 95% of our job is in communication, and often when things go wrong it's because a message has got a bit mislaid. So communication is really key to all of the work that we do. And for me, I guess what's important is to be able to distill that information, so to bring that level of expertise to the valuable information and voices that you hear from the patient, from their family and from care staff, gather that all together and then work with that to create a really clear plan to make sure that someone's wishes and values are respected. For me, I've always thought that nursing is very much an art and a science, so it's really important for me when I see someone to have that scientific knowledge and expertise. So if I'm seeing someone that matters to you, you want me to know what the right drugs are, what the right treatment options are, and what the evidence tells us is the best way to manage a symptom. But I also think, we often focus on pain, but it's also important to be aware of the range of symptoms that someone might see. So fatigue, breathlessness, nausea, they're all important to know what you might expect and how we can treat them and the options that are available to us, and what resources, and sometimes they're not exciting resources, but simple things like a small handheld fan can make as much of an impact on breathlessness as a range of medications. So it's important for us to know that. And we certainly have been very appreciative of the opportunities to attend conferences, have higher learning, and continue to make sure that we are able to be up to date with current practice and provide solid evidence-based practice to the work that we do. And we're very grateful, of course, for the foundation and sponsors who have been able to allow that to happen. For me, the most important and meaningful part, though, of what we do is the art of it, I think, and the getting to know people. It's a great privilege to be with a family and a person at this time of their life. And my favourite part of the job is listening to people's stories and seeing their photos of their grandchildren in their rooms and hearing them talk about the things that they've done in their life. I met a lady yesterday who had been a goat farmer, and she told me about her experience milking goats over the years, and that was extraordinary to think of the things that people have done over their lives. So it's the art, I think, of having those really difficult conversations. I often say to people it's much nicer to have that difficult conversation over a cup of tea in your kitchen than it is to have it at 3 a.m. in a hospital car park not knowing what to do. So it's important for us to be able to help people with that. And I get a great joy from talking to families and friends about life. And hearing what has mattered to them and making sure that the care that we deliver reflects what matters to them.
Thank you, Allison.
Thanks.
That's such an insightful look at the work you and the team do. Over to you, Anna. Outside of nursing home care, it seems like there has been a shift to people receiving palliative care in their home for longer. Can you tell us more about Sacred Heart's palliative care service in the home?
Yeah, so our community palliative care team is made up of about 30 to 35 people, and this ranges from doctors, nurses, physios, occupational therapists, speech pathologists, dietitians, psychologists, social workers, and our wonderful biography staff. It's a 7-day-a-week service that's 24 hours, so patients and their families can call us at any time. And really the priority of the community service is to support quality of life at end of life and for people to remain at home for as long as possible if they wish, as well as providing specialised follow-up to help people to navigate the complexities that can happen in a home environment. Like carer stress is a big area that we see in burden, functional decline and symptom management. And we really visit on an as-needed basis, so this can really range from sort of telephone calls monthly to daily visits. I also wanted to acknowledge that not everyone that we see in our service has a safe and secure home or has access to lots of family and friend care. Some people are quite isolated. And so we work with this patient cohort quite closely to support their wishes as best that we can. And I guess really highlighting the need to have access to a palliative care unit, timely access for that patient cohort too.
And what does that mean for family members and loved ones? How does the social work team support them through the process?
Yeah, so we've got 2 social workers that cover inpatient and community. And really, the aim of social work in palliative care is to support people and their social networks to navigate the psychosocial impacts that living with a life-limiting illness can have on our lives, like existential distress, an increased need for care, carer stress and financial stress. And one of the key interventions that we use is counselling as people navigate all the adjustments, changes and uncertainty in their lives. And I would say a key part of social work, and I think across our service, is really listening to people and giving them time to process and make sense of what's happening for them. And another key area that we work in is talking to families before and after a death and providing information about grief and the impact that it can have on our lives, like difficulty sleeping, a loss of appetite, challenges developing a new routine. But also recognising that a death doesn't only have psychological impacts, that it can affect a whole range of aspects in our lives too, like a loss of income, housing insecurity, social isolation, complex family dynamics, and social workers can follow up in this area in terms of providing information, counselling and advocacy work, as well as referrals. Another key area that I think our service gets asked a lot by parents and other members of families as well is how to have conversations with children around death, illness and dying, and what sort of supportive material can they access to help these conversations as well. And we really had a gap in our service in having access to these materials to support families to have these discussions with children. And so I wanted to acknowledge the estate of Shana McCann, who had chosen to leave a gift to support grief education at Sacred Heart. And through this funding, we were able to purchase some really important grief education materials and books that has helped us to support families in having some of these discussions, but also given an opportunity for children to explore for themselves these areas and formulate their own questions.
Yeah, wonderful work, so important. Advanced care planning is a term we are starting to hear more often. What is an advanced care plan and why is it important? And when should you consider having one? Davina, would you like to speak to that?
Thanks, Olivia. So advanced care planning is just planning for the future. It is having a conversation about what it is that you want or not want. It doesn't necessarily have to be at the end of life. It's actually important that you do it while you're well. And it's, I think Allison had mentioned some of the things that you don't really want to be in a stressful place before you decide what it is that you want to have done to you or not. And it is really putting in place some of the things that you find acceptable or not acceptable. You don't have to wait for a life-limiting illness to have that. So really it's about appointing an agent. So ACP, Advanced Care Plan, is appointing someone. So who would you trust to make decisions on your behalf if you were not able to? So that's the first thing. And then the second thing is communicate AC, right? So if you can communicate what it is that you think you would like done or not. In a palliative care setting, in an end-of-life care, life-limiting illness, it is thinking about, I would not want to be in ICU. I do not want to be in intensive care, or I don't think I would find if I can't eat or drink, that's not acceptable to me. So communicating what it is that you think is acceptable to you. The icing on the cake is putting it down on paper, so P, appointing an agent, communicating what your wishes are, and if you could put it down on paper, that will help the medical staff know what it is that you would like or not. I mean, that's icing on the cake. The most important two things actually is appointing the agent and communicating what you want. it is really not that scary. If for any of us right now, I've got an advanced care plan. My husband is the one who's going to make decisions on my behalf. So it's useful to start talking about it. It is a gift because it means that the person who's making the decisions on your behalf knows what you want. A lot of our families struggle with, did I make the right decision for mom? That's the worry they live with for the rest of their life. But if you're able to have that conversation now, then they said, mom told me before that if I couldn't do X, Y, Z, then that's probably the time that she would like to be made comfortable rather than having investigations or having intensive treatments.
Thank you. That subject is a lot less intimidating after that explanation. Rolf, you and your family were supported by the Sacred Heart Health team through a very difficult time. Would you be happy to share a bit more about this?
Absolutely. Thanks, Lavia. Good afternoon or good evening, everyone. Just a bit of background. Exactly a year ago in October, my mother-in-law was diagnosed with a very advanced ovarian cancer. At the same time, she'd been battling with dementia and Alzheimer's, so it was a bit of a slippery slope. After the diagnosis, everyone was called in to the oncologist, and she was given between 2 and 4 months to live. Fortunately, she was able to be with us for 7 months, and everyone had a longer journey with her than expected. Prior to that, we had no idea, no understanding, no family experience about end-of-life care, what palliative care really was, how it worked, and what resources. Fortunately, the combination of our oncologist and the GP advised that Sacred Heart or St Vincent Sacred Heart was the only place to go to, and we should go about the process of engagement, which we duly did. And it was that very first meeting, the understanding, the compassion, the attitude of the people. I think, as Allison said, it's not the care plan, that's the mechanics. It's more about how people approach you and the engagement that kind of made it work. And the journey began from there, where they explained what it is that one does, what do you do, how does it work. Very fortunately, my mother-in-law Reva had an end-of-life plan or a care plan, which was laid out during her wishes, as part of her last will and testament, etc. So it was pretty clear from the children what she needed to do. But still thinking it was going to be there for 2 months, what actually happened. There were a couple of interesting journeys that we went down. The first was the understanding of what was on offer and how we could be supported from Sacred Heart. And almost all the people that Anna kind of mentioned in there, whether it be the registrar coming to visit, the regular visit from the nurses, the dietitians, the occupational therapists, there's this continual support of people that would come into the home and actually really assist and help you. And then the confronting things as to what goes wrong, who do you talk to, who do you call, the keeping of morphine medication or any severe pain management medication, and who's going to basically administer it. Then we went through a slightly different process where we thought in late January that it was her time, and we had the support all the way through on the telephone. And yes, we did call out of hours on weekends, and there's always someone there. And Faisal's probably not here, but Faisal and Aaron and David are just unbelievable people. They call you straight back, or they answer the phone, and they're very calm, and they've got a very good plan to actually assist you at whatever time you need them. So we administered her into the Sacred Heart facility, genuinely thinking she had 1 hour, 12 hours, 24 hours. And I think you mentioned Dr. Chai earlier, who's the man's a genius, what can I tell you? And he basically, after 72 hours, said, listen, we've changed the medication, this is a new plan, she's not ready to go. I said, well, can you explain that? And I don't want to choose the words badly, but he said, I can confirm to you she's dying, okay, but she's not sick. So we went back home, and it was always her greatest desire to actually end her life at home. And during that time, we spent the next 5-6 weeks with her, probably 2 months at home. She had all the care and support, continual visitation, and the service was just unbelievable. And like everything, it was more about the people and how they interacted with Reva, how they supported the family, and how they dealt with tricky and difficult situations. And probably the most sensitive issue, to give some idea of the skills that the registrars and the doctors have, is they explain quite carefully that one of the difficulties in dementia patients and with the ovarian cancer is abdominal blockage can actually occur, and this can be removed with surgery, but obviously with dementia it's not done, and that's exactly what occurred. One of these situations arisen, the registrar was there, the 3 children were there, they were all in agreement and understanding of the end of care plan, and 2 of them acknowledged, and one, my sister-in-law, went straight, well, we have to operate, this is going to happen. And I thought, oh, how are we going to deal with this one now? And the registrar, I forget who it was at the time.
Jessica?
Possibly Jessica.
Or Sanjay, maybe.
And she said, I understand these are all the options. We are currently working according to the end of care plan that you've advised us. And if there's a change, please let us know. Would you like some time to kind of go through it? And we kind of settled down, and everybody's back in track in 5 minutes. And I'm nowhere near in the medical field. I've been in business a long time. And I just thought, I wish the people I worked with myself could handle tricky situations as well as that. But to bring, I suppose the bottom line at the end of the day is we had no idea. Without the support, the team, the care, and obviously all this experience and planning that's got into it, we would not have been able to get through the journey, let alone kind of make it to the other side. So once again, on behalf of the family, we just such massive supporters and so appreciative of all the work that you do. So thank you.
Thank you, Rolf. Your story really shows how this work can not only touch an individual's life and experience, but also ripple out to those around them. For me, being a part of that connection between patients, families, and in my case, our volunteers, it's a very special one. Just to give everyone a sense of what biography looks like in practice, the service at Sacred Heart was officially established in 2009. I co-manage the service with Emma Rossi, and together we support a team of around 40 volunteers. To begin with, each patient is carefully matched with a volunteer, and over a series of visits, usually in the patient's home, they sit together to record memories and reflections. Some biographies become full, that span a lifetime, and others are shorter pieces, such as letters, recollections, and some are written especially for children. From there, the biographer transcribes the story in the patient's own words, and so we don't take any creative license. It's captured in their voice, so when it's read back, you can almost hear them narrating it. Our team then supports the volunteer with light editing, structure, and presentation so that in the end, the patient and their family receives a beautifully bound keepsake, or 2 in fact, and a digital copy as well. The biography process really is a win-win-win for everyone involved, but most of all for patients and their families. For patients, it can be deeply cathartic, can offer a real sense of purpose, a framework for reflection, and a way to make meaning at a time when so much can feel uncertain. And for family members, what we found is it can open conversations that might not otherwise happen. Stories, the shared, memories rediscovered, moments of healing can occur. And so for volunteers and the wider team, it's an extraordinary privilege to be trusted with someone's life story. It's also a reminder that our patients are more than their illness, and that they've lived rich and interesting lives, as we've heard, and every one of us has a story worth telling. Biography also complements St Vincent's holistic model of care by supporting the emotional and spiritual well-being of patients and families, helping them to find meaning and connection when it matters most. So when we talk about legacy, it's not about a polished version of how someone wants to be remembered, but about the real story of how life has been lived and the values that have shaped it. And at Sacred Heart, that legacy can take many forms. sometimes through stories and sometimes through the generosity of those who choose to support this work in other ways. A big thank you to our panellists for being so generous with their time and sharing with us all your expertise and experience. We will now open the floor to questions from the audience. Can I please ask that you kindly wait until you have the microphone before asking your question, just to ensure our viewers online can hear you.
Thank you very much, everyone. My name is Wayne, and I am a volunteer here at St Vincent's. A pause for a lot of reflection. I was thinking, the famous American clinician Elizabeth Kubler-Ross wrote a number of books, put together a lot of books about death and dying, and one was a beautiful one called To Live Until We Say Goodbye. And I wonder if some of you have any thoughts or anecdotes about what spirituality, which obviously for St Vincent's is a key area, perhaps looks like in this field.
Davina?
Good question.
Yeah.
I think we are so privileged. I mean, this is the part of the reason why I've chosen palliative care as a specialty, because it allows me to ask patients about what they believe, what they worry about, and their spirituality, because it's clearly a part of whole person care, and that's one of the key things about palliative care is patient-centered care. And if you're a cardiologist or a renal doctor, if the cardiologist asks you, what do you believe in or what do you worry about, it's a little bit strange. But for me, I have actually got the license to say, no, do you believe in anything? And people accept that. That's part of my role. It's not you're a strange doctor kind of question. So I think it's a really key component. That's part of a holistic patient care. And to be honest, I don't think we do it enough. I think we need to do more of it. But it's definitely something that is part of the things that we do assess. And we are so fortunate to have a pastoral care team here at St. Vincent's. I've spoken to colleagues in other places, and they're just excited that they've just had a pastoral care worker like in the last couple of months. I'm thinking, we are so fortunate to have had our pastoral care team for a long time. So I want to shout out to our pastoral care team here as well. So it's definitely spirituality in the end-of-life care setting is part. Some patients get stress. One of the things I have learned about palliative care is the way you live is the way you die. So if you spend your life with family, community, it's likely that when we see you in Sacred Heart, or if you're in Sacred Heart or end of life, you have your family and community around you. But if you've been someone who's preferred to be alone, and there's various reasons why that might be, that's probably how your last days might be as well. So it's a real lesson for me in my life and how I choose to invest my time as well. So it's a very it's such a special specialty because it's got lots of lessons for us in life. I'm not sure if I've answered your question.
Any other questions from the audience? Okay. Well, thank you again, panelists. And
Another question.
oh, we do. We have one online. Excuse me. Okay. So, what if a family disagree? What if family disagrees about an end-of-life plan? Davina?
That's a really good question, and I think Ralph kind of alluded to some of the conversations that might occur when the plan is different from what the family, what is the patient's wish and what's the family's wish? At the end of the day, it's the patient's wish because it's their life that we're looking after. There's so many variations of this. If a patient has clearly put it down on a piece of paper, that is a legal document. So it has to be an advanced care directive. I don't want to get into the specifics, but an advanced care directive is a legal document. So we are obliged to follow what the legal document is. In fact, we try and work together with the family to try and bring them to the the same plan as what the patient would want.
Okay. Any other questions online? Oh, we have one at the back.
Hi there. Just one question regarding the Advanced Care Directive. It's a print document at home, isn't it, and witnessed by an independent, so you don't have to get a lawyer or solicitor involved with that?
No, there's a New South Wales Advanced Care Directive that you can Google and download that plan, and you don't have to get a legal person to witness it. You need a normal, anyone can witness.
And another one at the back.
Sorry?
Thank you. Davina, you mentioned that palliative care is not necessarily end-of-life preparation for death, but people can be living a long time with a life-limiting illness. What is the difference in approach in, say, palliative care and someone who is living with a condition, a chronic condition from which they will die, but that isn't necessarily, they're not necessarily under palliative care. They may have, well, I'm trying to think of one, but just what's the difference in approach from the care from a clinician who is managing someone with a chronic neurological disease and palliative care? How do you differentiate?
That's a really good question. So perhaps one of the things that we have is cardiac supportive care, and that's being led by Dr. Shampa Sinha, who's in the audience here. So in the cardiac supportive care clinic, it's with transplant patients or patients waiting for transplants. So they're clearly not theoretically at the end of the life, they're all waiting for transplants. So we are supporting our cardiology clinics, patients by having some of these advanced care planning conversations, but also trying to manage their symptoms. So whether it's breathlessness or pain, anxiety, mood disorders, we will have a conversation with them to assess them and to try and provide treatments which would be in keeping with their symptoms. It is a different mindset, but at the end of the day, it is patient-centered care. So what is their goal here in that setting, in the cardiac setting? It is about their goal is to wait for a transplant, but we do need to talk about, we wish everyone could get a transplant, but the reality is there's not many available hearts out there or available lungs. What happens in that time in between? What happens if there isn't availability? What would you want done or not done? So some of those clinics are right now the things that we do. For some instances, it might be completely appropriate to go into intensive care unit, and for some instances, maybe the patient has said, actually, if I can't get a transplant, then I just want to be made comfortable. So it's really about, at the core of our clinics is patient-centered care. Our approach might be different depending on what the patient is wanting.
Mine is not a question, but rather a comment, if that's all right.
Sorry,
my name's
Maria.
Maria Redding, and I worked in cardiothoracic for many, many years. But I did have the privilege to be in palliative care with a great friend of mine when she was dying. We started our basic training at the Mater Hospital together, and we were great mates for many, many years. She had 6 children, and I don't have any, but the 6 children, for the 3 days before she died, were with her, and the last day they brought in the Verve Clico. And the bottles pop all over the place. And I'd just like to say, nobody said a nasty word to us. That they were so good to us, and let them make sure we had glasses and even bought us a few snacks in. So we were very, very grateful for that. And on her coffin, they did have a champagne glass.
We are trying to set up our jolly trolley at the moment.
Okay, do you have time for one more?
My name's Katrina. I'm just interested, do you also have a sort of connection with people who maybe choose to have voluntary assisted dying at some point in the palliative process?
It's a really good question. I think that we have thought about this really hard, and we have tried to look after. So even before voluntary assisted dying became legal, there's comments from patients all the time like, I want to die, or I'm just tired of living. So that's actually a really common response, and our job as a palliative care team is to really explore what they actually mean. Because is it because their symptoms are quite bad? If, we need to address those things. And if it's something that patients still want to know more about, then we actually refer on to our New South Wales voluntary assisted dying team, so that the patients can follow up with the service for them to provide more information.
Well, thank you. Thank you again, panellists in the audience, for a very interesting discussion on palliative care services at St Vincent's Sacred Heart Health Service. I'd now like to invite Shantini Naidu, CEO of the St Vincent's Curran Foundation, to the stage to give the vote of thanks.
Good evening, everyone. For those of you I haven't met, I'm Shantini Naidu. I haven't met Olivia before. So thank you so much, Olivia, for your expert facilitation of the panel and your background on the biography service, which of course the foundation has been really proud to support over the years, and we are very grateful to our donors who've supported that service as well. Yes, of course, thank you so much to Dr. Davina and the team. You've done such an incredible job in transitioning from Professor Richard Chai's long-term leadership and ensuring that spirit and compassion embedded in Sacred Heart Hospice by the Sisters of Charity has continued. It's wonderful to see the teamwork in what is a very special speciality, as Davina outlined. Thanks also to the rest of the panel, especially Rolf. I think it takes a lot of courage to be able to come up and share such a personal story so honestly, and even the dynamics of your family, which I thought demonstrated particular courage, because it gave us that insight into the tension that can arise at that in those times when you're trying to make decisions under real pressure. I think Allison and Anna, your compassion, your connection to people, the points that you made about the amount of teamwork that it takes to provide the support that you do, but that very, very person-centred care, which is just so important in this extremely complex, as you can hear from what they were talking about. It's such a complicated area because it is all about humanity and healing and hope and dealing with people at a very fragile time in their lives and their family and friends' lives. I think actually tonight for me, the panel really brings home that combination of spirituality, compassion and practicality that needs to be kept in mind when we're dealing with what is a difficult conversation, not just with our families, but even to think about these concepts in our own lives. I thought, Davina, your ACP, your Advanced Care Planning acronym of, an agent communication and putting it on paper makes it seem so simple and practical. When I know we've tried to have conversations like that, it's like people don't want to talk about, I don't want to talk about dying, but it is something that we all have to do. I do want to thank people who support our palliative care services over the years, and in particular, as you heard from Richard at the beginning, and through the panel, we have relied really heavily on bequests, on gifts in wills, and the gratitude of patients and families who've experienced care to help us build and grow the service and provide those incremental programs that might not be otherwise enabled without philanthropy, like the biography service, like that equipment at home for people who can't afford to buy it but want to die at home. And that's interesting because it is, I think Davina said, it's not a very sexy area to kind of fundraise for and get people engaged in during their lifetimes. So we are really, really grateful to people who, consider leaving a gift in their will to support not just our palliative care service, but other areas of their health interest. And as always, we're very grateful to all our donors. You are our St Vincent's family of supporters, and the impact of your contributions, big or small, is very meaningful to us. I would like to thank Richard Haddock for spending many, many hours here today, for the amount of time and effort you've put into the foundation just this week, if not even this afternoon. I'd also like to, and give a special shout out to our board member, Louise Walsh. Thanks for being here, Louise. And to Charles Curran, AC, the Chairman of Trustees, for joining us, for their ongoing leadership, and a special shout out to John Cunningham, the founder of the Cunningham Foundation, who's also joined us today. Thank you all for being here, and I hope you enjoy your evening.